Oh, I have just noticed an error has crept in. Let's see where it is. Yeah, somewhere here. So we had initially here we had sites, okay? So that needs to be corrected as routes. Sorry for my mistake there. And here as well, so let's correct this also. It's not sides, it is routes, okay? While we are at it, let us also talk about something that we failed to discuss the last time round. Right, so here this patient told the pharmacist that he was currently taking, he had already taken paracetamol, okay? From a previous visit he had some paracetamol left at his place, and when he had similar symptoms he started taking it. Okay, so this was obtained on a previous visit. So the question is, what is an OTC? Okay, so drugs are broadly classified as prescription-only medications and over-the-counter. Okay, so this is prescription only. Okay, and this is over the counter. Okay, so this is a legal requirement. Okay, so a prescription is a legal requirement for prescription only medication. So that is why this physician has written a prescription. Okay, so it is for prescription only medications. Here in this prescription, amoxicillin is a prescription only medication. Okay, meaning a patient who goes into a pharmacist cannot obtain amoxicillin without a prescription. Okay, and the other class is OTC. OTC meaning over the counter, meaning you don't need a prescription, but it always helps if you seek advice from a qualified pharmacist before you self-medicate with any OTCs. Okay, so yeah, so we failed to explain what OTC was. Hope it's clear now. So that's a OTC. Okay. There was one other thing I think I need to here it is. So here it is names, okay? So I wrote a singular. Okay? So it's international non-proprietary names, and that is British approved name and United States approved names. Okay? Okay, sorry for those. Let us now discuss the routes of drug administration one by one. So the first route, let's take the oral route. So oral route means administration of the drug okay, drug or the drugs through the GIT. Okay. So let's try to explain this very diagrammatically. So let's draw something that resembles the GIT. What we are trying to represent here is the GIT. Okay, so to orient ourselves, let's draw a person here as well so we know where we are. Okay, so as we discussed earlier, that the GIT is basically a long pipe. Right? So that's what we are representing this. This is basically the muscular tube. Okay, it opens in the mouth or the oral cavity. And this represents the stomach. This is the small intestine. This is the large intestine. And this basically represents the anus, the nether opening. Okay. So, from an anatomical standpoint, we divide the GIT into four: the oral cavity, the stomach, the small intestine, okay, and the rectum here. Okay, so that is the rectum. Okay, so why do we divide this like this? Because it enables our study. Okay, but it has, as we know, it has got more than these parts. But anatomically, let's divide them into the oral cavity, the stomach, the small intestine, and the rectum. These four. Okay. Okay, and the oral cavity is. Okay, so where is the oral cavity? Somewhere in the head. Okay, we have the oral cavity. Okay. Yeah. So we are administering drugs through this pipe. So depending on where it is meant to act, so depending at the place from where absorption takes place, the important places would be this area here, which is the small intestine. Okay, so from a drug absorption standpoint, these are the most important areas. The small intestine, which begins from the duodenum there. So somewhere there is the duodenum. Okay, and this, the beginning where it joins the large intestine, This is the cecum. Okay, so this total length would be about, say, it is about 6 meters. Okay, so from here to there, so the small intestine, the length would be about 6 meters. And the diameter, so this is the length, the diameter, which is this distance, okay, this distance, the diameter is about 2.5 centimeters. Okay, so that gives an idea about what we are talking about. So the small intestine again is divided into duodenum, which is the smallest part of the small intestine in terms of length, duodenum, jejunum, and ileum. Okay, so from the cephalic region to the caudal region, it is, in order, it is duodenum. Okay, so first the food from the stomach would enter the duodenum first, then it will pass into the jejunum, finally the ileum, before the undigested food enters into the large intestine. So these are the parts of the small intestine. Okay, so these are parts of the small intestine. Let's write it down here. Small intestine, it has got 3 parts basically: duodenum, jejunum, and ileum. Okay, so drugs that are administered are meant to be absorbed from this area. They are meant to be absorbed in the small intestine, that area, and the rectal area, okay, that area. Okay. So when we say oral dosage form, we mean, based on this, what we have just discussed, we intend to talk about the oral, sublingual, and the buccal route. Okay. Okay. So these are the subdivisions of the oral route of drug administration, and then we have the rectal route. Okay. So yeah, these are all routes. Okay. So when we give oral dosage forms, they are meant to be either absorbed from the sublingual route, the buccal route, or the oral route itself. So if it is given through the oral route, it kind of travels down the stomach, goes into the small intestine. That is the area from which it gets absorbed. Okay. And the other thing to remember, this is basically a review of the physiology. The other thing to remember here is that after absorption, what happens from here, through the intestinal wall, it gets absorbed, and outside the intestinal wall are these blood vessels. Okay. So say we are talking about the food gets absorbed into these blood vessels, and then these blood vessels travel to the liver. Okay. They travel to the liver, which is located somewhere there. And then the liver does some chemical changes in the absorbed constituents of the food. and then releases it back into the blood. That blood goes into the heart. The heart then pumps that blood through different parts of the body, and so all parts of the body receive the nutrition that is absorbed. Okay, so that is what happens for food. Now, we are administering the drug through this route, and it basically, whatever happens to food is going to happen to the drug. But the drug is basically not food. It's not a nutrient. Okay, there are nutrient drugs, and there are drugs which are given as food supplements, like in total parenteral nutrition. But generally, drugs are not food and they are not nutrients. Therefore, they are called xenobiotics. Anything that is not a food or a nutrient, it is called a xenobiotic. Okay, so drugs are basically xenobiotics, which travel in the same route as food, and then they bring about certain changes in the body. Okay, so yeah, so now that we have oriented ourselves to this diagram, we can take our discussion to drugs. So if a drug is given through the oral route, it can act in two ways. As we previously said, it can act either locally or it can act systemically. Okay, so an orally administered drug may have a local effect or it may have a systemic effect. Now, if let's talk at examples of local effects. Suppose this patient has got acidity. Okay, it's producing lots of HCl. Okay? And that can cause ulcers either in the somewhere in the small intestine, or it can cause gastric ulcers. Okay. Gastric or duodenal ulcers can be caused. So this patient has got this problem. Okay, but right now let us think of this patient as having early stages of acidity where there is no lesions. Okay, it doesn't have ulcers in either the gastric ulcers or duodenal ulcers. Okay, so this person, so he's managed with antacids. Okay, antacids. So his problem is acidity, and something that is used against anti-acidity. So we combine those two words, we get acidity. So antacids are drugs acting against acidity. Okay, and these are meant to react with the acid present here and neutralize it. Okay. So the action is what is happening in a local area. Okay, so that is an example of a local action. Okay, antacids. It's an example of a local action. So what are the antacids we are talking about? Let's give some concrete examples. Okay, so there is aluminium hydroxide, okay. Magnesium hydroxide, then there are stronger ones like sodium bicarbonate. Okay, but the thing is, this drastically alters the pH. Okay, sodium carbonate, sorry. Sodium carbonate. Okay, so this can rapidly change the pH. So if the pH suddenly goes into an alkaline pH, the body will start to produce more acidity. Okay, so it might not solve the problem, it may worsen the problem. Therefore, this is not a drug of choice. So what is currently being used is aluminium hydroxide and magnesium hydroxide. Okay, but this aluminium has got a problem. It can cause constipation. Okay, on continued use it may cause constipation, and magnesium hydroxide continuous use can cause laxation. Okay, so that is something to be remembered about aluminium hydroxide and magnesium hydroxide. But having said that, these are examples of antacids having a local action. Okay, then another small thing to remember along with this is these basic chemicals are combined in various forms with alginic acid, in various formulations with alginic acid and simethicone. Simethicone is an anti-flatulent. Okay, meaning it is anti-gas. Okay. Alginic acid, it basically acts as a barrier, okay, to the acid. Acts as a barrier to the acid. Okay, so different formulations of aluminium hydroxide, magnesium hydroxide exist with these. Okay, so now you know why they are used. So simethicone basically reduces the surface tension. Okay, so it doesn't, it prevents eructation, which is the acid contents being refluxed into the esophagus. Okay, so this is an anti-gas, anti-flatulent effect. Okay. All right. So the other where you can have local action is in the rectum. Okay. For example, for hemorrhoids. Okay. You can give anti-inflammatory drugs through the rectum, and there it is going to act on the local area. Okay. Or say in pediatric patients, let's say glycerine suppositories. Okay. Glycerine suppositories can be given in pediatric patients if they have constipation. What is constipation? Yes, so there is lesser frequency of evacuation of the bowels. So we call it constipation. And then what do you do in constipation? You try to use a laxative. Okay, so glycerine suppositories, they act osmotically. Glycerine is having osmotic action. It will pull in fluid from the surrounding tissues, and there will be increase in bulk of the fluid, and that bulk will cause local propulsive movements, and that will translate into evacuation of the bowels. But where is glycerine acting? It is acting locally in the rectum. So that is another example of the local action of a drug which is administered through the GIT. Okay. Systemic are the drugs which we are all familiar with, which is meant to give a systemic action. So these drugs are meant to get absorbed from either the sublingual route, the buccal route, or the small intestine, and they are designed to enter into the blood, and after entering the blood they have their effect. Okay, so that is why it's called systemically acting drugs. Okay, so to understand more, let's look at a prescription. Yeah. Let's look at this prescription. So this prescription is of a patient. His name happens to be Roger, and he had a respiratory tract infection. Okay, upper respiratory tract infection. So it was an upper respiratory tract infection. Maybe he had a strep throat. Strep throat, okay, which is caused by streptococci. Yes, streptococci infection, and he had, say, pyrexia, which is fever. Okay. Okay. And the pyrexia was had subsided. So at that point in time, he had visited the physician who gave him this prescription. Okay. So what is this prescription? Let's look at this. Tablet. Okay. Acetyl. Okay, this is a trade name. And what is it basically? It's an antibiotic called Erythromycin. Okay, so this is the generic name. And that is the trade name. Okay, and the physician doesn't want the pharmacist to substitute. Therefore, he or she or this doctor has asked the pharmacist to, directed the pharmacist to dispense as directed. Okay, not to change. And he says, do not repeat the prescription. So repeat prescription should not be given. All right, and let's look at the other information that we can gather from this prescription. Okay, we see the dose. What is the dose? This is the dose. Okay. And this is how it has to be administered. Okay, so 8 hourly, right? Okay. Once a day. Okay, not 8 hourly. If it is 111, then that is 8 hourly. This is 100. Okay, meaning you need to administer only once daily. So that is OD. Okay, once daily for 3 days per oral. Okay, has to be given orally. Okay, so what do we understand? That it is a tablet that has to be administered orally. Okay, so it is a tablet. So what do we understand? That it is a tablet. Okay. So what is a tablet? A tablet is a, what is it? It is a solid dosage. Okay. Do we know of other dosage forms which are solids? Yes, we do know. Okay, so the most common ones would be tablets and capsules. Okay, so it's a solid dosage form. Any other solid dosage forms? Yes. If suppose you go to a dispensing pharmacist, they might give you, and you got a prescription from a physician, they might give you powders. Okay. These are again solid dosage forms. Right, so in this case it is a tablet, it is a solid dosage form, and we understand that this tablet has got, it is, in addition to being the solid dosage form, it is uncoated. Okay, so if it is uncoated, it means there are also coated tablets, which brings, so we realize that there is more than one type of tablet. Okay, so let's make a list of what are the different types of tablets which are available currently. So let's write types of tablets. Okay, so there are basically 9 types of tablets. One is a compressed tablet. Two is a multiple compressed tablet. Three would be an enteric coated tablet. Four would be a sugar coated tablet. Five would be a film coated. they're all tablets. 6, what could be the type of tablet? It is chewable tablets. Chewable tablets. 7 would be effervescent. 8 would be Buccal and sublingual tablets. Okay, they are different, Buccal and sublingual. And 9 would be vaginal tablet. Okay, so let us look at this prescription again. Now, it is already a tablet. Okay. And then the physician has mentioned per oral. Okay, so it would sound counterintuitive because a tablet is supposed to be given by the oral route. Then why does he mention per oral again? Okay, that is, if we look at the classification, we will understand. Okay, there are also vaginal tablets. Okay, therefore, he has made himself precise. Okay. So any prescription like this that comes, there are few things that we need to, as healthcare providers, look into. Okay. Okay. We need to look at the 6 rights. Okay. So let me write it down here. We have to check whether either if we are writing the prescription or someone is dispensing the prescription. Okay, but either way, we should look at few things. One is that it should be a prescription for the right patient. Okay, it should be the right drug. It should be in the right dose. And it should be given by the right route. And it should be given at the right time. And the patient should have the right to refuse the treatment. Okay. So as healthcare providers, we might be very altruistic, we might be wanting everyone to live, everyone to have the best life possible, but that is what we think. Okay, the patient might have a different outlook on that. So whatever the patient's desire reigns prime. Okay? Okay. So based on this, let's again look at the prescription. Okay, so it is for a male who is 53 years of old, right? Because he is at this age, we have to check the dose. Okay, so he is a fully grown adult, so we have found that the dose is correct. Okay, so it is the right patient and having the right dose. Okay, so we need to. If we are from the nursing profession or from the clinical pharmacist or we are a physician assistant, we need to assure ourselves that this is the right person for whom the prescription has been written. Okay? Okay. So we have checked if it's the right drug, if it is the right dose. Then we also need to look whether it is the right route. So now we are very clear that it's given by the per oral route at the right time. Okay, so this is a once daily a drug that is administered once daily, so that is correct. Okay, and the patient obviously has not refused, that is why he got a prescription in the first place. So it is administered at the right time. Okay, so these things have fulfilled. So our analysis of the prescription begins with this. Okay, as we are discussing about the dosage forms, we try to look at other aspects first. But anyway, it is instructive for us to keep this in mind. Okay. Okay. All right. So let's look at some details in this drugs. So what are compressed tablets? Compressed tablets are basically the conventional tablets. Okay. The conventional tablets with which we are familiar. Then there are multiple compressed tablets. So this may have greater than one drug. Okay, they may have more than one drug. And so their release might be controlled. So those compressed tablets, release might be controlled. Then there are enteric coated tablets. What are enteric coating? Enteric coating. So enteric coating is the coating of tablets with polymers. So what can be the examples of polymers? It can be cellulose, acetate, phthalate. Okay. So polymers like cellulose, acetate, phthalate. So what is it doing? Why do we coat the tablet with a polymer? It is basically to protect the drug against degradation by the acid present in the stomach. Okay. So we coat it to protect the drug against the degradation by the acid present in the stomach. So suppose in case the drug is acid labile, so protect the drug. What is the property of this drug then? It is acid labile. Okay, so it protects the acid labile drug against degradation. Okay, so coating would protect that. Okay, to protect the drug. There are actually other reasons also as to why the drug is coated with a polymer. So let's write this number 1. Okay. The second reason why it is enteric coated is to protect the GIT against irritation by the drug. Okay, so you're protecting the drug, you're protecting the GIT. The third reason would be to protect and reach the drug in sufficient quantity to the GIT so that more can be absorbed. So technically we said to increase the bioavailability. Okay. So the idea is, suppose there is a drug, say 100 milligram is being administered. Okay, it is degraded in the stomach and only 10%, 10 milligram reaches the small intestine. Then only 10 milligram out of 10 milligram, all 10 milligram won't be absorbed. So maybe only about 3 will reach the blood eventually. Okay, so if you protect it, what's going to happen? Maybe say 90 milligram reaches. Okay, you protect. Okay, so when you protect, 90% reaches the small intestine, Out of that, maybe say about so from 10 we get 3, 10, 90, maybe 27, okay, would reach the blood. Okay. Still it is greater than 10 and it's a better idea. So that's what we are trying to explain here. So the third reason is that to increase the bioavailability. Okay. So that is the reason why enteric coating is done. So do we have examples of drugs which are given by enteric coating? Yes, we do. What are the drugs which are enteric coated? So let's write here examples. Okay, let's make some space. So examples of enteric coated drugs which are administered clinically to patients. So the important examples would be Erythromycin. Okay, this is an antibiotic. Okay, this gets degraded by acid in the stomach. Then there is another drug, Omeprazole. This is a proton pump inhibitor. So this is an antacid. Okay, one of the most potent antacids, which acts systemically. Then aspirin. Okay. So aspirin, what's the generic name? Acetyl salicylic acid. Okay. So that is the generic name of aspirin. Now aspirin has got this property, it can cause ulceration. Okay. So this is a drug-induced ulceration. Okay, so because it is this acid. Okay, so what can we do? We can prevent the effect of aspirin on the stomach. Okay, by enteric coating it. So this is available. Even the regular aspirin and baby aspirin is about 75 milligram dose. Okay, so baby aspirin is also administered as a enteric coated form. Okay, so this baby aspirin, the effect is antiplatelet. Okay, so it prevents the platelets from sticking and thereby it will reduce the risk of thrombosis. Okay, thrombosis is basically blockade of the blood vessels. So that is blocked if you use low dose aspirin. Okay, so that is a very important example. The other example would be Bisacodyl. Okay, so this is basically a contact laxative. So what it does is it irritates GIT and thereby it promotes, increases peristalsis. Okay, and thereby relieves constipation. Okay, so Bisacodyl. Okay, Bisacodyl is a drug. So how many examples do we have of enteric coated drugs? We have looked at 4. There are many others, but we won't make the list very big. Okay, at least this 4 should be remembered. Okay, and Bisacodyl, and we know we have learned the indications for these drugs as well. Okay. So if you look at the classification again, if you look at 3, 4, and 5, okay, so these are basically coated tablets. So coated tablets are of 3 types. What are they? Enteric coated, sugar coated, and film coated. Okay, so film coated is basically you can control the disintegration of the tablet and thereby control its release. So there are different types of film-coated tablets. So when we look at absorption, we're going to come back to this. So please hold on to this thought and wait for our lecture on absorption. Okay. So let's look at chew tabs, okay, or chewable tablets. So these are basically very flavored and kind of tasty tablets, but also containing medicaments. And the examples would be calcium carbonate, okay, 500 milligram chew tab, okay, chewable tablet. So what is this used for? Again, it's an antacid, so calcium salts, magnesium salts, and aluminium salts. Okay, let's write it down here. Usually calcium salts, magnesium salts, and aluminium salts. They are all antacids, okay? Okay, so this is a general thing that has to be remembered. The other thing to be remembered is this aluminium basically forms a gel, and that gel does not increase the acidity like sodium carbonate does. And that is why it is preferred. Okay, so it's one of the leading antacid preparations is made of aluminium. Okay. Magnesium, the good thing about magnesium is it's a dose-dependent reduction in acidity and peristalsis. So if you increase the dose, if you drink massive amounts of magnesium hydroxide, you're going to have laxation. If you take less dose of it, it acts as an antacid. Okay, so yeah, and the adverse effect of aluminium salts? Yes, constipation. Okay, so chewable tablets, we have looked at examples. There is another chew tab. So in small kids, if there is a vitamin deficiency, then a vitamin C chew tab can be given to children. They find it very palatable. Okay. There are also preparations of baby aspirin, okay, as chewable tablets, though these are the more important ones. Okay, effervescent tablets. Okay, so effervescence. If you look at the word, effervescent is derived from effervescence. Now, effervescence means bubbles or fizz. Okay. So these drugs are meant to produce bubbles or fizz when they come in contact with water. So when they are administered along with water, they form effervescence. Okay. And what are the chemical constituents? If we look at the chemical constituents, things become very clear to us. So let's look at this. It is basically an acid-base reaction. So there should be a base and there should be an acid. Okay, so the acid, let's look at it. First I'll use a different color. Okay, so the acid could be citric acid. And we need a base. What could be the base? It could be sodium bicarbonate. Okay, so acid plus base reaction will give carbon dioxide, okay, in presence of water. In presence of water, it will form carbon dioxide, and that carbon dioxide is responsible for the bubbles or the fizz. And if suppose along with this you give, say, sodium carbonate, then it can act as an antacid. Okay. Antacid, this entire thing can act as a antacid preparation. Okay, but the active principle would be sodium carbonate, and these are just making the bubbles or the fizz. Okay. Citric acid can also react with sodium carbonate, so again it can release more of a fizz. Okay, as well. But sodium carbonate would preferentially act on HCl, okay, because that's a stronger acid, and this is a stronger base. Okay, so that's how the neutralization reaction would happen. Okay. So the next important one is buccal and sublingual. Okay, so buccal. What is buccal? Let's look at what we mean by buccal. So buccal basically means the dosage form is introduced between the gum and the cheek. Okay. So this dosage form is meant to be held there. Okay. So the patient should be counseled that they should not eat or drink for at least 15 to 20 minutes after administration of the drug in this form as a buccal form. So what are the examples we can look at? We can look at, let me use another pen here. Okay, so Prochlorperazine. Okay, so this is used against nausea and vomiting. Okay? Nausea is when you feel sick, and vomiting is when you vomit due to this sickness. Okay, so it's used against nausea and vomiting. Then there is fentanyl. Okay, so this is again administered as a buccal tablet. So this is number 1, number 2. So what is this used for? This is basically a painkiller, and it is a strong painkiller. So it is not meant for pains like headache or minor pains, minor pains or aches. Okay, it's not meant for that. Okay, so what is it meant for? Is for breakthrough pain. Okay, breakthrough pain. So what is breakthrough pain? So it's in cancer patients, okay, who are under opioids. Okay, so opioids like morphine, they are painkillers. And these patients are given morphine to manage their pain. But even when they are having morphine, sometimes they may experience pain. Okay, so that is called breakthrough pain. Okay, so the pain was restrained, but it breaks free. Okay, so that is why it's called breakthrough pain. And so for the management of breakthrough pain, fentanyl citrate is administered. Okay, so that is our second example. The third example that is given as a buccal preparation is miconazole. Okay. So miconazole is basically an antifungal drug, and so this preparation, when you give it into the cheek, it is meant for a local action. Okay, suppose the patient has got a candid infection, okay, a fungal infection in the mouth. Then this drug would be given as a buccal tablet. And what will happen? This buccal tablet will slowly release the miconazole into the mouth. And that will act on the fungally infested tissue and kill them. Okay, and so that's the mechanism of action of this drug and the rationale behind giving it as a buccal tablet. The other example would be, say, hydrocortizone. Okay? Hydrocortizone. Again, hydrocortisone is an anti-inflammatory agent. Okay, so if there is an inflammation in the mouth, you can again have it for local action. Okay, so these are the examples. So what are these? These are examples of enteric coated. Not enteric coated, Buccal preparations, Buccal tablets, all right? Okay, so which brings us to sublingual. Let's look at some examples. Oops, this is getting stuck. Okay, anyway. So sublingual tablets. These are very important from the healthcare provider's standpoint because sublingual tablets, and there are very famous ones in sublingual tablets. We have got nitroglycerine. Okay, so this is also called glyceryl trinitrate. Glyceryl trinitrate. Okay, so this drug is indicated for the rapid release of relief of pain in a patient having myocardial ischemia. Okay, so it's to relieve pain in myocardial ischemia. So the therapeutic action would be obtained about, say, 1 to 3 minutes after administration. Okay, so let's discuss more about this. Let's make some space here. Okay, so let's bring our discussion from there to here. Okay, so we are talking about sublingual. We are talking about ischemic heart disease. Okay, and the complication of that is myocardial ischemia. Okay, so anyway, ischemic heart disease is, let's say this is the heart, and the heart, the muscle of the heart, which is called myocardium. Myocardium is supplied by coronary blood vessels. Okay, so if there is deposition of cholesterol on the blood vessels, the lumen of the blood vessels will become thin. And if suppose this is the normal lumen, and due to deposition of cholesterol, it becomes plaques. Okay, so plaques will deposit on the walls of the blood vessel. As a result, here the diameter, say, is about 2 millimeter. Normally, here it would become maybe 0.01. Okay, so the lumen size decreases drastically. And so what happens is, what are these blood vessels doing? They are bringing fresh oxygen and nutrients to the myocardium. Now, what has happened? The lumen has become very small. As a result, this myocardium will not get enough nutrition or oxygen. As a result, they will have ischemia. Okay, so ischemia basically means decrease in oxygenation. Okay, so there is decrease in oxygenation. The muscle is not able to do work, but wastes are accumulating, and so that is a problem. The body gives a sign to the body itself that I am in trouble by having, there will be referred pain. Okay. Referred pain. Okay, because it is the visceral pain. Okay, so this heart is the visceral organ. What are visceral organs? Visceral organs are organs which are present within the body cavity. Okay, inside the body cavity. So visceral pain is a referred pain, So if it is a skeletal muscle, suppose you have got, this is your thigh muscle, okay? So this is thigh muscle. And somehow you sit on a seat and there is a pin, okay? And that pin injures your thigh. Immediately you can know, you will feel pain. And if someone asks you, where exactly do you feel the pain? You are able to pinpoint the location because it is a skeletal muscle. This is a skeletal muscle. But if it is an organ which is present inside the body, it's a visceral organ having smooth muscles, cardiac muscles. What happens is you won't be able to localize the pain. Okay. So in a general area, you will begin to feel pain. And sometimes the pain is referred to the shoulders. The problem is in the heart, and you might have the pain. Where do you have the pain? You might have the pain on your shoulder. Okay, so the pain from the heart is referred to the shoulder. So it is called a referred pain. Okay, right. So these are the symptoms of ischemic heart disease. And then you are giving sublingually, you are going to administer glycerol trinitrate. So what that does is it increases the lumen size. It brings about vasodilation. Okay. So glycerol trinitrate basically it increases vasodilation. So what does vasodilation mean? The lumen size increases. Okay, lumen size increases. So now what happens is, if there is increased lumen size, increased amount of blood will enter into the myocardium. That increased amount of blood will bring in more oxygen, more nutrition, and then the problem will be relieved. Okay. So if it is not relieved in time, if you don't give glycerol trinitrate, what will happen is these muscles will die. Okay. So it will form an infarct, then you might have a cardiac arrest and you may die. Okay, so that is why as soon as the pain comes or you feel uneasy, you are immediately given sublingual glycerol trinitrate. Okay, which brings us to the point why it is given as a sublingual tablet. Okay, so the number one reason is that it has got a very onset of action. Action is very fast, 1 to maybe 3 minutes. Okay, so this is an emergency. You need it to act very fast. Okay, so if you give it sublingually, it gets into the sublingual mucosa, and from there it will be absorbed. It will bypass the arteries, it will get into the veins, and it will reach the heart immediately. Okay. So the question is, why can't you give it orally? If you give it orally, what will happen is it will get absorbed, and as we previously discussed, the blood will go from the stomach. It will enter into the blood vessel, and that blood will go into the liver, and the liver will basically chemically modify glycerol trinitrate. And then after modification, glycerol trinitrate will be released very less in quantity into the blood, and that less quantity is not enough to relieve the problem. And this process will take a long time because you are giving it through the stomach. Okay, so that is why one of the reasons why we are giving it sublingually. Okay, so the first reason is that it has got a very fast onset of action. The second reason is, as we just mentioned, it bypasses the liver. So we said blood goes into the liver, and the liver chemically modifies it. The chemical modification by the liver, so chemical modification by the liver after per oral administration and absorption into systemic supply. Okay, so this is called first pass metabolism. First metabolism. Okay, so we said that it goes into the veins, and from there it goes into the systemic circulation. It bypasses the liver. If it bypasses the liver, it won't undergo first pass metabolism. Okay, therefore does not undergo what? First pass metabolism. Okay, so there the bioavailability will be much greater. Okay, so these are the reasons that this drug is given sublingually. Okay, all right. So the thing to remember, there is an important fact to remember about glyceryl trinitrate, that it is meant to dissolve immediately in fluid, okay, containing water. Okay, so the drug is formulated using glyceryl trinitrate and then sucrose or lactose or glucose is used to make the tablet. So as a result, the tablet is designed to immediately dissolve in water. So the tablet is very sensitive to humidity. So therefore, the patients and we ourselves should understand this so that we can counsel the patients to keep or store these tablets in a very cool, dry place. Okay, and that can minimize this problem. Okay, and the tablets needs to be, it cannot be stored for a long period of time because it will undergo degradation. Okay, so fresh tablets should be used. The patient should not hoard it. Okay, so if they hoard it and use it after a long time, it might not have the desired effect, and that may have an undesirable outcome in the patients. So as healthcare providers, we need to know this. Okay, so this is a very important class of drugs that we need to be concerned about. Okay, so the last one here is vaginal tablets. Okay, so this vaginal tablets, it is not an oral route. Okay, so we should be, this is just for information. This is not given by the oral route. It's not given by the oral route. So this is just for completion of our discussion. We are going to talk about vaginal tablets. So vaginal tablets, let's give example and then try to explain. One example would be estradiol. The other would be again progesterone. Nystatin. Okay, vitamin C. Okay. Commonly, these are the common drugs which are given as they are administered as vaginal tablets. So the reason estradiol is given is that it is given to women who are undergoing menopause. Okay. So menopause is a condition in women where they cease to produce the eggs. Their estrogen level really comes down, and as a result, they'll have dryness, irritation, etc. Okay, of the vaginal tract. So that problem is mitigated if we use estradiol. Now, progesterone is a fertility drug. Okay, so in couples who are trying to conceive, the women might be administered progesterone as a vaginal tablet. A vaginal tablet and nystatin. This is an antifungal drug. So if women has got fungal infection, then this might be prescribed as a vaginal tablet. And vitamin C, this is basically given in bacterial vaginosis. Okay, so what is bacterial vaginosis? It is a condition where there is alteration in the normal microbial flora. Okay. Normal microbial flora in the vagina. Okay, so this vitamin C as a vaginal tablet is indicated in bacterial vaginosis. Okay. So we began our discussion by looking at this particular prescription. Okay, we said that this patient was administered a tablet. So we said tablet was a solid dosage form, and therefore we looked at different types of tablets because we have the information that this is a uncoated tablet. So if it is uncoated, there will be lots of other types of tablets, and we have discussed which are the most important types of tablets. So we will limit our discussion to tablets because our prescription contains only tablets, but we must be aware that these things are also applicable for powders and capsules. Okay, so the general concepts are applicable even to other oral dosage forms. Okay, let's come back to our picture here and add some more information here. So the pH of stomach, we should know the average pH in the stomach would be 1.5 to 3, so which is pretty acidic. And the pH in the small intestine would be about 7 to 8.5. Okay, so it's pretty alkaline. Yeah. So we said enteric coated drugs, they are protected in the acidic pH, but they disintegrate and dissolve at alkaline pH. Okay, so that is the reason why enteric coated drugs are so useful. The polymer has got this property. Okay, it does not degrade in acids, but it degrades in an alkaline pH. Right? Okay. So that's the important thing that we should remember. The other thing to remember is that theoretically the drug that we administer can be absorbed from the oral cavity, it can be absorbed from the esophagus, it can be absorbed from the stomach, it can be absorbed from the small intestine, it can be absorbed from the large intestine, it can be absorbed from the rectum. Okay, but that is theoretical. Okay, so maximum absorption takes place at the oral cavity, at the small intestine, and at the rectum. So initially we said, we gave an example of a local action at the rectal route. We said we gave glycerine suppositories, but the rectal route can also be used for systemic absorption. Okay, so antipyretic drug, let's say the same pediatric patient, we are giving paracetamol, not paracetamol, let's take a better drug, say diazepam suppositories. Okay, so pediatric patients whose fever cannot be controlled by either tepid sponging or paracetamol, such patients are at risk from convulsions. Okay, so they can have febrile episodes of epilepsy. Okay, febrile convulsions. They are at risk for febrile convulsions. Now, what is the problem? These febrile convulsions, if they come, it can permanently damage the brain. Okay, so in such infants, diazepam suppositories is administered. So what happens? Diazepam is administered. That diazepam will get absorbed through the hemorrhoidal veins, and again it will reach into the systemic circulation. Okay, but it is not very efficient for systemic absorption. Okay, but in a pediatric patient, it is one of the best interventions that can happen. Okay, so the rectal route can also have systemic absorption. Okay, so in the GIT, the oral cavity, the small intestine, and the rectum, the drug can be administered, and therefore those three we have considered in some detail.